Hope everybody had a good weekend. So we've got 5 people here, so in addition to me. Just put this on. Okay. 1, 2, 3, 4. Well, we give it another minute or two. We're a little low on fellows. Give it 1 more minute and then we'll get going. Okay. All right, I see we have large enough. Okay, that sounds good. Okay. Why don't we get going? Okay, we go to David Barris. Hi, David. Good morning.
Morning, Dr. Pess.
This is a 3-year-old who had an ingestion of some sort, and this is the patient's electrocardiogram. So you're asked to consult or comment on this tracing from the emergency department. What do you think about this?
So first, I'm just kind of looking at the rate here. Looks to be a little bit faster than 100 beats per minute. Just moving on to rhythm, I'm seeing P waves before every QRS, and I'm seeing P waves upright. In one, I'm seeing P waves upright in AVF. And now I'm kind of just looking at our intervals and our voltages here, and I'm just seeing that it looks like there's almost like an alternating voltage. Will have one higher QRS and then one that's a smaller voltage and a higher voltage and a lower voltage. The rhythm looks, sorry?
I said I agree.
But the rhythm looks regular other than that. Just kind of looking at our axis now, again, upright in one, upright in AVF as well for each of those 2 QRS complexes. And then in terms of our intervals, nothing really jumps out as grossly. I've actually maybe on the large QRS complex, the P waves look kind of close to the QRS complex in one.
Mm-hmm.
Like that's a pretty small PR interval, but the smaller QRS complex, the PR interval looks more normal. Maybe, I mean, I'm trying to convince myself if that's possibly delta wave or not in one. Just because there's this, I do see, especially in that second large complex in lead one, I do see a slight angle on the upstroke of the QRS.
Yep. So what do you want? How would you like to describe this tracing?
So
I agree with you that the patient
intermittent, I guess there's like intermittent pre-excitation, sinus rhythm, normal access with the second word is alternans. I'm trying to remember what the first word is. Electrical alternans.
You could call it QRS alternans, I guess, but
QRS.
But really, the proper term is your prior statement, which is that this is an example of intermittent pre-excitation. Now, this is the tracing. Let's see here. I think I have another one of the same. This is the tracing of the same patient 10 minutes later, just as an FYI. Okay.
Now it's more consistent.
Right. So can you say anything about this patient and their WPW based on these tracings?
That they can be induced into a more persistent pre-excitation?
Well, I think more perhaps more properly, we would say that they intermittently are continuously pre-excited versus this tracing where they are not.
Mhm.
Can you say anything about the patient's risk for sudden cardiac death based upon these tracings?
I would say that it's higher since you can go into continuous excitation.
Well, what constitutes high risk for a patient with WPW? How do we define that? And well,
Uh,
first, let's even take a step back. What are we worried about with WPW? What is the risk that we're worried about?
so that they would go that the pathway can conduct very fast, and that if they go into AFib, they'll conduct extremely fast, and then their ventricular rate will be extremely high, and they can have sudden death.
Right. So your atrial fibrillation in the setting of a rapidly conducted pathway could cause ventricular fibrillation, which could result in sudden cardiac death. That's correct. So does the fact that the patient has intermittent pre-excitation, and then in this tracing is fully pre-excited, can you make any comments about this pathway and the level of risk that it has?
I mean, my initial thought was that if it can be if it could turn into a consistent pre-excitation, that might indicate higher risk, but I'm not really sure.
So you're right. If somebody is consistently and persistently pre-excited, particularly at faster heart rates, that is generally considered a higher level of risk for a patient to have pre-excited atrial fibrillation and sudden cardiac death. But the point I'm trying to make is that intermittent pre-excitation generally would connote a lower risk pathway. And that is what the American Heart Association, the American College of Cardiology, and the Heart Rhythm Society said in a 2012 paper by Mitch Cohn. He's the first author, but it's a statement. And basically, one of the statements they make is that if you have an asymptomatic WPW patient and they have intermittent pre-excitation, that should be considered an indirect sign of probable low risk. Um, and uh, and in the setting of an asymptomatic patient, if somebody is intermittently pre-excited, according to that document, you do not have to do further electrophysiological testing. Um, that has been called into question by many authorities because there are cases of patients who have high-risk pathways who have had intermittent pre-excitation. Let me give you an example. If you had a pathway that was very far left lateral, you could imagine that because the AV node is physically closer to the sinus node than an accessory pathway, that one could, in the setting of elevated catechals, have enhancement of AV nodal conduction, making it less pre-excited. And actually, you could potentially even lose pre-excitation because the time it takes to conduct from the sinus node to the AV node may be much shorter than the time it takes to go from the sinus node to a left-sided accessory pathway. Therefore, that would be an example where someone could potentially lose pre-excitation, but the pathway still is conducting. It's just that the ventricle is being depolarized faster because the AV node has enhanced conduction and is physically closer, meaning that the conduction time from sinus node to AV node is less than the conduction time from sinus node to accessory pathway. And so for this reason, a lot of people feel that although the formal recommendation is that intermittent pre-excitation is a good sign, and I think that in general, on average, that is probably true, it is not something we can definitively hang our hat on. And there are rare cases of patients who even had formal electrophysiologic testing, had a low risk accessory pathway, but then died suddenly. That is thankfully very rare, but it is at least been described. And for that reason, slowly, it seems that a lot of electrophysiologists are moving towards the notion of ablating everybody on the theory that it is difficult to predict who is at high risk. I don't really agree with that approach, but that is an approach that a lot of electrophysiologists are doing. What they'll often do is say that they try less hard on patients who have accessory pathways that don't seem to have high risk characteristics. My personal bias is that the enemy of good is better. As many of you have heard me say in the cath lab, I would be inclined to not go after pathways that don't represent high risk, at least according to the criteria we have. But I think the point is also that the criteria that we have established are not necessarily the only criteria. And I think we also overdiagnose people with high risk, right? If you take people to the cath lab and study them, probably 20 to 30% of them will end up at quote unquote high risk. But we know that 20 to 30% of people with WPW do not die suddenly. And so therefore, almost by definition, we are overestimating the number of patients who actually are at high risk for sudden death. That said, generally speaking, and the correct answer on the examination is that if you're intermittently pre-excited, you probably are not high risk. And so it's just something to keep in mind when you're thinking about these patients. Okay, let me move on to the next.
Dr. Pass.
Yes.
You said that there was some kind of ingestion. Was it digitalis or something else, or digoxin?
That is an excellent question, Sergey Babia of now New York City, previously Russia. Excellent question. It is possible that if someone were to take dig or what's another agent that could enhance accessory pathway conduction?
Calcium channel blocker.
Right. So verapamil or diltiazem, all three of those agents would be big no-nos in people with WPW, particularly older patients. And we've talked previously that some cardiologists do think it's okay to use digoxin in very young infants with WPW. But certainly anybody over the age of 1, it would be contraindicated absolutely to give either digoxin or a calcium channel blocker. And in fact, I believe this is not my case. This came from that wonderful doctor in Hawaii who was nice enough to send me a lot of his tracings, Dr. Flanagan, Colonel Flanagan. And I believe this was actually a digoxin ingestion. So anyway, an interesting case, and definitely, something to think about when you're looking at a patient. What are in the electrophysiology lab, Sergey, how would we know, how would we test if somebody is high risk or low risk? What is the technique that we use to determine this?
We check how fast the accessory pathway can conduct. If it's above 250 per minute, then it's a high risk.
That's right. So one way we do that is by rapid atrial pacing. Okay. And that is in the electrophysiology world, they call this the SPERI, or the shortest pre-excited RR interval. That's one way. Another way is that we actually can induce AFib, because conduction through the pathway may be different in AFib than it is with rapid atrial pacing. And I've had the situation where we've done rapid pacing and we can conduct fairly quickly, but then in AFib, there's virtually no conduction at all. That's probably the best test. And actually, this number of 250 milliseconds, which is roughly a rate of 250, this actually came from a paper I've mentioned many times from George Klein. And in that study from 1979 in the New England Journal, Dr. Klein took a bunch of patients who had arrested. He brought them to the cath lab and he intentionally put them into atrial fibrillation. These were adult patients and the patients were awake. And that's how he came up with those numbers. And we still to this day use that. Another mechanism we can assess risk is by checking the refractory period of the pathway. And again, generally, if the refractory period is less than 250 milliseconds, we would consider that to be a high-risk pathway. The problem, of course, with EP testing is that in my experience and that of most people, most patients end up in the gray zone. They're neither low risk. Low risk would be defined as being able to conduct at rates below 200 beats per minute or a cycle length of 300 milliseconds, nor are they high risk, greater than 250. They're somewhere in the middle. The other problem with invasive testing is that in children, we routinely do these procedures under general anesthesia. And so if a patient is under general anesthesia, we don't really know what these numbers are supposed to be. So as a surrogate for being awake, in order to try and simulate what Dr. Klein did in 1979, electrophysiologists routinely give isoprel. the problem with Isoprel is that you can dial in the dose to whatever you want the pathway refractory period to be. And in fact, a number of studies have shown that if you're on Isoprel, as many as 20 or 30% of patients who were not high risk off Isoprel become or meet criteria for high risk on Isoprel. So again, obviously, we know that much less than 20 to 30% of patients are at high risk for sudden cardiac death. What is the risk for sudden death in WPW, Sergey? Do you know? What do we believe that risk is statistically?
Not sure.
It's thought to be about 1 per 1,000 patient years. Some people would say 1 in 1,000. Some would say 1% over a lifetime. It's very difficult to know because we don't know the denominator. But I think the bottom line is that given how difficult it is for us to accurately predict who's really going to die, I think that we have become more liberal in our interest in ablating people, but we do have to remember that there is always a price for every invasive procedure. And, that one patient who gets heart block because asymptomatic patient because they were in the medium risk category is going to be a difficult pill to swallow for somebody. Hopefully not me, and hopefully not any patient. Okay, let's move on to a different type of case. This is a tracing from a remote monitor on a patient who has a defibrillator. And I think I see that Dr. Keelan is on the line. We're going to take advantage of her since she is a imager and not an electrophysiologist. Jenna, do you still have to take your boards, or are you already board certified?
2.5 weeks. I'm taking them.
All right. So my question to you is, what happened on this tracing? And then we can go from there.
All right. So I'm just trying to take a look here. So it looks like it starts out in somewhat of a normal rhythm, and then it goes into this faster rhythm. That looks like VTAC initially. And then sort of on the bottom line of the tracing.
This is continuous, by the way, just
yeah.
in case, yeah.
But of like the two lines on the bottom line almost looks like it goes into torsades. And then potentially there's a shock, and then we get converted back into sort of, it's maybe a ventricular paced rhythm actually, because the QRSs are wider than the first ones that we see.
All right. So yes. So this patient had spontaneous ventricular tachycardia, and ended up getting shocked. Now, my first question is: so one thing to say is these are recordings from within the defibrillator. This lead says RV tip to ring. So this is basically the tracing recorded on the end of the sensing lead of the defibrillator. And this is the can to the coil. So this is just the coil is the large defibrillation coil that is a little bit proximal to the electrodes, the pacing and sensing electrodes. It's on the distal end of the lead. It's just a different electrogram that can be recorded by the device. So although I agree with you that if this were a QRS, this looks like torsade, remember that the term torsade is generally formally polymorphic ventricular tachycardia in the setting of a long QT interval. It's really supposed to be used predominantly for people with long QT. Also, this is not a QRS. So the rapidity of the tracing, though, and the manner in which the electrogram is changing so rapidly, which is, I think, what you meant by describing it as torsade, suggests that this is ventricular fibrillation. Okay? So I guess my first question to you is, looks like it's the patient's in it for a long time, right? I mean, it's at least, I don't know, something on the range of about 12 seconds. Why is it that the device took that long, do you think?
Let's see. I mean, I think if you look and there's an arrow that says detection, so it did take a little while for it to get detected. Then trying to think, if you look down on the bottom with those sort of lines underneath the tracings,
Yes.
is that what the ICD is sensing?
I believe it is, yes.
Okay.
So I'm going to just interject here because this isn't an easy question. That's why I chose you, because we knew you were very smart. It's because, well, first of all, you notice that it took about maybe a second and a half to detect this arrhythmia. But it doesn't mean that the device didn't detect it. It means that Dr. Love or myself set a criteria to the device for what it is going to consider to be VF. And usually, because we don't want devices to shock inappropriately for sinus rhythm, and we really only want to treat rhythms exactly like this one, we would want the device to only detect or consider to be a ventricular arrhythmia, very, very rapid rhythm. So probably it was programmed with a detection of a rate of 220 beats per minute. Additionally, because anybody can have 2 or 3 PVCs at that rate, and because we don't want the device to shock someone for that, patient has to be in it for a certain length of time. So in the case of this device, which is a Medtronic device, you have to tell it what percentage of beats in a row are at that rate in order for it to consider itself to be ventricular fibrillation. And so it probably, so for example, you might say 12 of 16 consecutive beats above 220 would be considered VF, or 16 of 20, or 24 of 30, something along those lines. So the device is very sophisticated. It is constantly monitoring the R-to-R interval, and it is also constantly looking at intervals of that length in order to see if the criteria are met. And so in this case, at that point that the word detection is there with the arrow, what that is a way of telling us that the device at that point felt that the criteria for ventricular fibrillation had been met according to the program that had been set by Dr. Love. Now, interestingly, you notice that those lines that are underneath the tracings do not correspond to all of the beats, meaning there are some beats that are missed.
Right.
That demonstrates an important feature of defibrillators, which is that sometimes the leads, the ventricular fibrillation can become so fine that the device can't sense it. And you can, in fact, sometimes have undersensing of ventricular fibrillation so that the device can't tell that the patient is in it. I had a patient once like this, a baby, and in fact, the device could not detect the VF because it was so fine that even though the R wave that it measured in sinus rhythm was like 6 or 8 millivolts, in VF, it couldn't detect it at all. And for that reason, we ended up having to list that patient for transplant because there was no way to be certain that the device could be programmed to properly sense the arrhythmia. This period here is basically the charge time. So once the device has reached detection, the device will then charge. You may ask, why doesn't it just start charging from the moment it senses a rate over a certain amount? And the reason for that is simply battery savings. If it were to charge every time it saw, say, 3 or 4 beats at 220, it would probably use up a lot of battery. So once the patient has met the detection zone, the device will start charging. And in this case, the device is programmed to deliver 36 joules. And 36 joules is the maximal output of this particular device, meaning it has to charge fully. And so that typically takes, well, in this case, it only took about 3 seconds, 3 or 4 seconds, which is very rapid, actually. Some devices can take as much as 10 seconds. And then at the time that it is fully charged, which is probably somewhere around here, the device is also programmed, once it's fully charged, to re-look for a period of time. Most times it's 1 second, to reconfirm that the rate exceeds the detection zone of 220, because during the charging, it's possible that the VF may self-terminate, which of course would always be preferable to a shock. Once, in fact, though, the patient is still in VF, then the device will deliver the shock. And what you see here is that, as you correctly said, Jenna, after defibrillation, the patient is in ventricular paced rhythm. And that is not uncommon, that the heart rate is very slow initially. So in most defibrillators, there is a setting to program what they call the post-shock pacing. And so usually for approximately 30 to 60 seconds, you program the device to pace at a slightly faster rate than usual, so that you can confirm or be more certain that there'll be a reasonable rhythm after the shock. Now, if you got shocked and you were in sinus tachycardia and that you set the program, let's say at VVI at 60 for 1 minute, then of course it would be not pacing and you would be in sinus rhythm. But in this particular case, the patient had no rhythm, and so it's a good thing that the device was pacing a little faster. Also, when you've been shocked, your pacing threshold transiently will rise. And so typically when you set the post-shock pacing, you typically have to pace at a higher output. So usually we'll set it at a very high output to maximize the chances of ventricular capture in the pacing following a shock. This patient actually, although this is disappointing that this patient had this arrhythmia, it was useful in proving that the device was effective in both sensing and shocking. Now, you notice that it missed a number of the beats of VF, but it met enough of them. That's one of the reasons why there's this moving window looking for a certain percentage of the beats to be sensed. And in fact, when we are doing defibrillation thresholds in the cath lab, one of the things that we're checking when we induce VF is how well does the device sense. And if every other VF beat is undersensed by the device, that's a good sign that the device is not in a good position, that the lead is not adequate sensing. Now, we don't do defibrillation thresholds very much any longer, because studies have shown that if in sinus rhythm the R wave is larger than a certain amount, if the pacing impedance and threshold are good, the likelihood that the lead will sense properly in ventricular fibrillation is reasonable, as well as the likelihood that it will successfully defibrillate someone. So that's the reason why when we're putting defibrillators in patients in the present era, we don't usually check defibrillation thresholds unless there is a specific concern. But in this case, I think this is clearly shows that although the sensing isn't perfect, it was pretty good, and it certainly was easily able to terminate the arrhythmia with a single shock. Okay, any questions on this, Tracy? All right. Okay, why don't we move on to the next? So I just wanted to go over, though, ventricular arrhythmias and life-threatening events in patients with repaired tetralogy, because this is a patient with tetralogy, and this is sort of a very difficult topic in pediatric cardiology and adult congenital cardiology, which is predicting who amongst patients with tetralogy are truly at risk. And this paper just came out earlier this year from the group in Boston, a multi-center study. I think there were 13 centers, and what they did was they retrospectively assessed patients who had had ventricular tachycardia or had arrested, and they tried to come up with factors that would help predict who has tetralogy and is at risk for life-threatening events. This is like the holy grail of electrophysiology predicting, and there have been many, many studies on this topic. And they came up with an interesting algorithm called a variable importance factor. And essentially, it's like a scoring system similar to the one for long QT syndrome patients. And basically, these were the factors that gave patients higher risk for the development of a ventricular arrhythmia. And they were able, they had over 300 patients in this study who had ventricular fibrillation. And what they found was that there were differences in what the patients, how important certain risk factors were in people who were repaired in the 1960s and the 1970s versus patients repaired in the 1980s to 2000s. And this likely reflects two things. One, the age of the patients being older, but also the surgical technique. In the 80s and onward, surgeons tried to do most tetralogy repairs transatrially, whereas in the 60s and 70s, it was not uncommon to make a much larger right ventriculotomy. So symptoms, you could see in both eras, was a very important factor. I think in this study, nobody arrested who had not had some kind of palpitation symptom with syncope before. LV dysfunction, which is not intuitive, right, to people with tetralogy. It turns out if you have LV dysfunction in the moderate to severe range, that actually this is a very bad prognostic sign for someone with tetralogy. Now, of course, this is true in normal patients who do not have congenital heart disease, that LV dysfunction is a bad thing in regards to risk of sudden death, but it is also similarly bad for tetralogy. And this is perhaps not intuitive because in tetralogy, of course, we think of a right ventricular disease, but just as in everybody else, LV dysfunction is very important. And there have been prior studies, particularly looking at the left ventricular end diastolic pressure and that being a very good predictor, or at least a predictor of sudden death. RV dysfunction, particularly in the older era, was a more important factor, but is still something of a factor. If the RV pressure is elevated to a moderate or severe degree, that is a factor. If the RV is volume loaded, that is a factor. The age at repair. So in the 1960s, people got repaired a lot older, and so that was a risk factor. If you had a shunt before repair, this has been shown in a number of studies that shunting patients may enhance risk, although it only gets a 1 in the more recent era. The complexity of the repair, I assume this means, more patching, et cetera, some more higher risk. QRS duration has been shown in some older literature to be a risk factor. In this study, it was a risk factor, but a small one. And then, interestingly, sustained and non-sustained VT. And so basically, the maximal number of points one could get in the 1960s to 70s in this scoring system is 17. In the 80s to 2000s was 14. And if you exceed any of these numbers, they call them low, moderate, very high, and very high. This has not been studied prospectively. This was a retrospective study, and probably this needs to be validated in a prospective manner, but it is at least a nice way of thinking about all the different factors and trying to come up with some best guess as to who is at high risk for sudden death with tetralogy. But I thought it was useful to go over this because many of these factors are the factors that in many, many different studies have been demonstrated to be more or less important. And based on patients who had died or nearly died, the authors were able to assign degrees of importance of these factors and how relevant they were to the 300 patients who had had life-threatening arrhythmias or cardiac arrest. Okay. Let's move on to a different patient and a different topic. Grace Kong, this is a 17-year-old in the emergency department with palpitations. She is sitting there talking to you. Unfortunately, you have this very old-fashioned EKG machine because you are the newer models are all being serviced, but they took out this old one where you have to handwrite which leads are which. So what do you think is going on here?
Mhm. It looks like the rhythm is irregularly irregular.
Mm-hmm.
So I would call this, but it's wide complex. I would call it AFib with rapid conduction, with ventricular conduction.
Right. That's correct. So this is an example of WPW with pre-excited atrial fibrillation. Very important. You probably have noticed that probably 2 or 3 weeks do not pass that I don't show you a tracing of this nature. And that is
Yeah.
because this is a very important thing to identify that you will one day be called upon to identify, one of you at least. And so I don't want you to miss this diagnosis. So the patient's in the emergency department, is actually talking to you, says, I don't feel well. What are you going to do about this, Grace? Also, by the way, he just came back from, he just had a cheeseburger at McDonald's just before he walked in the emergency room because he was hungry.
I would want a synchronized cardiovert.
Okay. So he's saying that he feels some heartburn because he just, he had a milkshake with that hamburger. How are you going to cardiovert this patient? You're going to do this awake?
Oh man.
You call anesthesiology to sedate the patient.
Yeah.
Dr. Hollinger starts screaming at you that she doesn't really like having to sedate somebody who has a hamburger and a milkshake in their stomach 30 minutes ago. She'll do it, but she wants you to know that there's a high risk of aspiration, pneumonia, and death. Do you have any alternatives that you might consider trying?
You could try procainamide.
Right, you could try procainamide if you happen to have some lying around. And what would the dose be of procainamide, by the way, since you brought that up?
I would be guessing.
So normally we would give about 5 per kilo, but usually you would need probably 2 or 3 of those 5 per kilo doses. But generally we would do it in aliquots of 5 per kilo. That tends to be less hemodynamically embarrassing. What is the most common hemodynamic effect of procainamide?
Hypotension.
Hypotension from vasodilation. So if you gave somebody procainamide, you would certainly want to have volume available, and you would have to be ready to cardiovert because this could degenerate into VF at any moment. So you would make the patient NPO, and it would not, by the way, be wrong to sedate and cardiovert this patient. It's perfectly reasonable, or defibrillate this patient. It's just a higher risk anesthetic, but anesthesiologists have to do high risk intubations and sedations all the time. That's what happens in the field. That's one of the reasons why people who come in on ambulances often have pneumonia, because during intubation, they may aspirate, stuff like that. But there are techniques, obviously, to avoid that when you're intubating a patient in that scenario. So yes, it would be perfectly reasonable to call anesthesiology, sedate the patient, and cardiovert them. But if you wanted to try to avoid that, you could give procainamide. What does procainamide do, Grace? Why would that be helpful? I agree with you. It is the right idea. But why is that a good idea?
Does it the accessory pathway conduction?
Yeah, it's a slow accessory pathway. Yes, it will prolong the effective refractory period of the accessory pathway. Also, atrial fibrillation could terminate with procainamide as well. So it has 2 possible benefits for the patient. You could give IV amiodarone as well, but procainamide would be sort of the more proper answer for this. Other than now, if you were going to shock this patient, would you do a synchronized shock or an asynchronous shock?
Synchronized.
I'm sorry?
Synchronized.
Why is that?
It's an atrial tachycardia, and you wouldn't want to induce a VFib if you were to.
So you would want to synchronize to the ventricle, And how much energy would you use for this?
You could do 0.5 to 1 per kg, joules per kg.
That would usually be the right dose. I agree with that. Okay, let's move on to good answers all. So let's see here. Let me see if Dr. Lawali, I believe, is on the line. What is this rhythm, and what would you do about this?
Morning, Dr. Bass. So just looking at the rhythm strip, that's the question. You see P waves in the first one, the second you don't. Sort of grouped beating, but so I think, and there's not much PR prolongation. If it is, it's really subtle that I'm not able to pick that up on this.
So for those in the audience, you're asking about that because we've talked about how sometimes patients who are wanky-bocking will have group beating. I assume that's what you mean.
Right.
But that is not, in fact, what's happening here.
Yeah. Let me see. I don't see any P waves that are not conducted.
I agree with that.
Is this, and I can convince myself that the P's are related with QRS. It's not like it's complete heart block. Just sinus pauses. Is this like sinus node dysfunction of some sort?
Well, what's happening on this beat here?
So that's a PAC.
Right.
Okay.
And
then there's a pause.
And this is a sinus beat. Sinus beat. And then what's this beat?
Again, a PAC.
Right.
And then a pause.
And then a pause and a sinus beat, and then another PAC. So this is atrial trigeminy, I guess you could call it, meaning every third beat is a PAC. And when you have a PAC, it can sometimes enter into the sinus node and reset the sinus node so that you have a pause. This is not uncommon. We sometimes see this in newborns in the nursery, and it gets our neonatology friends nervous because they see overall a very slow heart rate because the PAC causes sinus pause. But this is generally a benign finding. We would not normally treat this, but it's just important to recognize that notice that the PR interval on these PACs is not long. Now, we've talked about how the AV node is decremental, meaning that when you put a PAC in, you should see a longer than average PR interval. In this case, it's actually very similar to the typical or the normal PR. And that's because if you look at the axis of the P wave, it's coming from the inferior portion. In other words, that P wave is a low right atrial P wave, very close to the AV node. So even though it is early, because it is so close to the AV node physically, the PR interval is not particularly long. If this were a P wave, an extra P wave, an ectopic P wave coming from an area other than the sinus, near to the sinus node, or in the left atrium, far from the sinus node, the PR interval would likely be much longer on the premature beat. Okay, so because remember that the AV node conducts in a decremental fashion, meaning that as we get more and more premature, the conduction will slow slightly. So this is an example of atrial trigeminy, probably from a low atrial focus. And in an asymptomatic patient, this is not a particularly worrisome finding. So it's 7:45 now. Why don't we call it for this morning? Thank you for joining, and we'll see you next week, I guess. I'll see you actually in 15 minutes at sign out. So any questions about what we've discussed today? No, we're good. All right. Thanks, everybody.
Thank you.
Have a wonderful
Thank
day.
you.
Talk to
Thank
you
you.
soon.